Hello, and welcome to today's health webinar. This episode is brought to you by our friends at DaVita. We would like to remind you that the Q&A feature is available, so feel free to send in your questions and comments throughout today's webinar. We would love to hear from you. And with that, I will turn it over to our moderator, Francesca Tentori.
Hello, everybody. Thank you so much for attending this webinar. I'm excited today to host a really great panel to discuss a topic that I think is super timely, which is how can we use AI to help us manage multiple chronic conditions. My name is Francesca Tentori. I'm a nephrologist and epidemiologist, and I'm a VP for Outcomes Research and Patient Empowerment at DaVita. DaVita, as an organization, provides care for more than 250,000 patients with chronic kidney disease and kidney failure. Kidney disease is a complex condition and typically presents itself in people who also have multiple other comorbidities. So I'm really excited to learn from this panel today how AI can help us moving forward better manage these patients. First, I think we should do a round of introduction. Neil, do you want to go first?
Yeah, sure. Thank you, Francesca, and thank you for joining us on this webinar. My name is Neil Patel. I lead the ventures team at Redesign Health. We're a venture builder, and I've had the pleasure of working with both Steve and Rishi on a number of things over the years.
Steve? And you're muted.
Thanks, Francesca, and great to be with you all. So Steve Phillips, I oversee DaVita Venture Group for DaVita, which I would think of as an innovation and growth enabler for DaVita, focused on venture investing and broader investing, inclusive of M&A. One point about DaVita that I'd love to add, Francesca, on and build off what you said is that I think DaVita is often thought of as a dialysis company. And if you go back 7-8 years, that is largely what we did for our patients. But who we are has evolved to be a fairly large value-based care organization. So as you think about common comorbidities, diabetes, hypertension, palliative care, behavioral health, those are all things that are in scope and we are trying to solve and support our patients around.
Absolutely. And Rishi, do you want to go next?
Yeah, awesome. Thank you, Francesca. So Rishi Madok, I'm CEO and co-founder of Linea. My brief background, I'm an emergency physician and clinical informaticist with a background in digital health and kind of building companies over the past 12 years. Linea itself was born out of redesign and a partnership with DaVita, thinking about how do we identify and engage patients with heart failure and simply prevent their readmission, but add value back and solve for problems for all the stakeholders in healthcare. So super happy to be here and looking forward to our conversation.
Thank you all for being here. I think it's really exciting that we have a concrete example of what collaborations across organization has yielded, and hopefully you will be able to share some of the benefits that this collaboration has yielded. But first, I would like to start with a fairly broad question. So as a clinician, and if there are clinicians in the audience, we know that the burden of comorbidities and chronic conditions is just growing as population ages. And so we have more and more conditions to take care of and not necessarily more resources. So for each of you, I would like for each of you to kind of weigh in and share your thoughts on how technology and perhaps specifically AI can help clinicians and healthcare system manage multiple comorbid conditions. Neil, do you want to go first?
Yeah, of course. So I'll take this broadly from a broader disease management AI standpoint and maybe level up a little bit to kind of how we think about tech-enabled services businesses and how they've transformed with new next generation artificial intelligence that's available, and that a lot of companies, Linea as well, are kind of applying in new, really inventive ways. There's a number of kind of applications. One is if you think about it like the clinical bucket, the other is in the operational. And I would say that we're seeing transformation across both vectors, and both are equally exciting because one thing from a venture investors and a venture builder standpoint is that one of the knocks on tech-enabled services business historically has been, gross margins tend to be somewhat capped and value accretion to, the company and the investors comes through massive scale. And I think one thing that we've seen is that when you apply artificial intelligence to be able to, automate certain workflows, to be able to really optimize your resources, you're able to, decrease the cost of providing really, really high quality care. And then you can also apply it to that actual care interaction as well. And so we see this applied to a lot of verticals, going from diabetes all the way through congestive heart failure and other verticals. And it's a really exciting time to be, kind of at this early stages of company development.
Yeah. Which I think is exactly one of the ingredients that made our collaboration successful. Rishi, do you want to weigh in on that initial question? Maybe kind of connect to Neil's considerations.
Yeah, just to double click on what Neil was saying, right? I think is that like so much of healthcare comes down to, the right solution, but at the right point in time, right? And so being able to like take a single data point, like an elevated potassium or a presentation to the ER or, an admission to the hospital and a discharge, but then take those data points, drive an insight from them, create a task and an action, and then ensure that it happens has been amongst the greatest challenges in healthcare, right? How do you coordinate across that? We often know what to do, but applying it to when and actually getting it done has always been that scalable like challenge, an operational challenge to Neil's point, right? It's costly to do that from the traditional healthcare perspective. When you think about technologies like generative AI or agentic AI, right? Both the reactive and proactive capabilities, right? And what we've seen is the ability to orchestrate these actions and these events. And so really to collapse down the time to get from data point to action and realizing it's happened, but also being able to drive in the right person or next agent, right? So that idea that like I can bring a care team in to talk to that patient even before they're discharged from the hospital, right? And then use an agent to schedule their cardiology and nephrology follow-up and have that all in place before 24 hours from, after the patient's released to the outside. And then all of that comes back down to patient level, right? So that the patients feel that they have this personal advocate with them at all times. And that's really made possible by using technology and then bringing, humans in the loop, a clinical care team in the loop. But then the real value is then taking that personalized level and breaking it out to population level. You can do it for every single patient all the time, right? That scalability of quality interaction and care is the unique opportunity right now with what we see in technology and using AI as the infrastructure, right? It's not the why, but it's the how we get there. And it's frankly, just for us, it's been changing how we work. And, to Neil's point, like it changes those operational costs as well.
And I think I'm not sure there are many skeptical clinicians on the call, but I think that's really the magic word is scalability of personalized care. Like I think I'm a great doc, but I'm only one person. And so how do you actually scale it at a population level? That is the magic. And it's probably where your fancy AI words become less scary to people who just want to deliver great care for every single patient in a very, very large number. Speaking of large numbers, Steve, what are your thoughts and reactions?
Yeah, no, maybe coming at what Rishi hit on from a slightly different angle, I'd flag that DaVita's in a unique spot where we have certain markets where our patients can get referred to, providers in a market. There is such massive fragmentation in some of those markets that for certain services, they can get referred to north of 100 different providers. And across those providers and whatever service they're engaging around, they have a different experience that leads to different outcomes and differential cost. And it's that where I'd say technology can both engage to really do two things. One, increase access that can happen more quickly as you think about where agents can play a role in lower acuity events. And then two, and this is exactly where Rishi was headed, standardization. And if tools and capabilities can really get at clinical next best action that informs a base level of care that all patients can experience, you can envision a world where there is a rising tide that lifts what is that base model for all patients.
Got it. And maybe we can transition to a concrete example of what our recent collaboration through Linea has been. Just to set the stage a little bit from a clinical perspective, congestive heart failure is a condition that is very common among patients with kidney disease, and specifically those with kidney failure. It's one of the main driver of hospital admissions and resource utilizations overall. So a big problem for us to solve, and to solve at scale in a large population. So, Rishi, Steve, do you want to elaborate a bit on how we got to the collaboration and maybe some of the benefits that we have been able to observe so far, as well as the challenges?
Yeah, I'm happy to take a first stab. For Linea, when we started the company, the focus was, patients with heart failure get admitted frequently. And when they get admitted and discharged, the readmission rates can be that 40 to 60% number, across the US. So high cost, high morbidity and mortality amongst this population. But we also have solutions in place that we know can work, right? If you get a patient on GDMT, which is 4 medications, get them on, titrate them up aggressively, you can reduce that readmission rate. But doing that is hard because they need lab results, they need someone to coordinate that care. There are a ton of other issues that could be a whole other webinar for it. When we sat with DaVita, and DaVita obviously is known more for kidney care, knee-jerk reaction would always be around dialysis, but also in CKD, non-dialysis patients as well. This population also carries its own comorbidities, and patients don't just have one comorbidity, right? So the crossover rate between heart failure and CKD or ESRD is also oddly 40 to 60%. Maybe it's just the number that I always remember. But the idea there is that, as I've said frequently, we saw ourselves as taking care of patients with heart failure, but heart failure ends up not all that we do, right? Our goal is to engage the patient and keep them healthy, keep them out of the hospital, and focus on this 90-day episode after a discharge to really show concrete value to all of our stakeholders. And part of what made our collaboration with DaVita work so well is being able to understand, a large entity that's doing this at scale currently. What is their process? How are they identifying and breaking up that whole process from a patient's discharge to hopefully preventing a readmission, or what causes that readmission, and seeing what are the steps that are applicable to what Linea wants to do in heart failure, and sitting down and actually working with the IKCRNs and the IKCAs and speaking to the nephrologists, and to your point, Francesca, speaking to the cardiologists and involving those relevant stakeholders into the product building conversation has made us successful, right? Is that it's allowed us to take their clinical workflow, and not for us to impose a new one on them, but rather saying, how do we take our innovation? How do we take these broad concepts of AI and whatever else and insert it into clinical workflow, driving to a very concrete outcome, which is drop the readmission rate to 20% and below, which is what Linea's focus is. And then working backwards from there is what really led to our success, is by constantly keeping those stakeholders in the loop. So that to me has really yielded that successful collaboration between, DaVita and Linea. Steve.
And for people in the audience, IKC is the DaVita name for our value-based care programs, because we tend to use a lot of linkers that might not be as familiar to others. I'm sorry, Steve, you were jumping in.
No, I was just going to build off of what Rishi said and talk a little bit about the why up front, right? And CHF, as he articulated, falls into the bucket of sort of unfortunate comorbidities that many of our patients are navigating, and it's one where there are protocols that we have a pretty high degree of confidence in that can move the needle and bend the trend for our patients. And at the same time, there's a high degree of fragmentation, as Rishi indicated, and not too many patients are able to be adherent to those protocols. And so for us, it was, is there a solution that exists that could create some standardization at scale, as you think about DaVita and having a population that spans across the country? And we came to the conclusion that there was not a perfect solution, which is why we decided to partner with Redesign and then Rishi to stand up what I think is a new and exciting company and capability. What I would add on the capability point to what Rishi said too is that I do think is more exciting than I had initially appreciated is just the ability to engage patients. And as you think about what I believe is perhaps the biggest challenge in healthcare today, it's exactly that. And I think Linea has deployed a model that intervenes at a point in time when patients are more excited to engage and begin to make a shift in behavior that then yields them a positive outcome in terms of feeling more healthy. And that creates the stickiness that is so valuable as you think about your behavior change and changing trajectory.
Yeah,
To be honest, that was super surprising to me, and I would love for Rishi to elaborate more on that, because as a clinician, I was super skeptical that anybody sitting in the hospital would actually be reading a text or picking up a phone call. And yet we are seeing that that is a time, maybe due to vulnerability, that patients are willing to engage. And so, Rishi, can you talk a little bit about how that initial encounter, which is not truly an encounter, but connection, carries forward, and how that enables your model care?
Awesome. Yes. So for Linea, right, like our approach was to think about, all right, when you want to engage a patient, if you pinged a patient on a normal day for them, right, on a Saturday morning when they're out, but maybe they're attending their kid's soccer game, they're going to see that text and they're going to say, that's nice, you have a heart failure program, and then put it away, right? Because it's not really, we are people. We have other priorities. An admission to the hospital is a significant event for people because it's extremely disruptive. It takes you out of your job, it takes you out of your family life, takes out of your things that you really enjoy, and sticks you in a hospital bed. And suddenly you're poked, prodded, and told what to eat and when to eat, and what you can do. And it is very difficult for patients and very disruptive, especially when it's an unplanned admission, which is most of the time. So we saw that as an opportunity to also say, this is a time where people will be very invested to making sure this doesn't happen again. And can we find these patients when they're admitted to the hospital, and can we engage them? When we first sat down with DaVita and learned the process of how it's done traditionally and talked to other, ACOs and risk-bearing entities, the task seemed very daunting. Like it was, there are armies of people who call and figure this out. And so I was actually quite worried. What we did is we looked at what's commonly done, right? ADT feeds, to try to identify and watch or kind of provide surveillance of when eligible patients could be admitted, and not just admitted to the hospital, but present to the ED room. So when you present to the ER, we have an idea of when you could be admitted. And we start to prepare the resources, anticipating an admission, because the admission rates are very high in this population. Once you're admitted, we're able to engage. And so the system is actually looking past your prior records, creating a clinical summary, but also mapping out who your providers are, where you might be sitting, what's the phone number for the specific, floor that you're admitted to for heart failure in that hospital. And you might get a call via the hospital phone when you're sitting in bed. You might get a text on your mobile device. We may even reach out to your designated and approved point of contact. And, we introduce ourselves and say, listen, we're here, just to, help you through the admission process. And as you get ready for discharge, we're going to create a plan that aligns to you. What's actually happening on the back end for the system is it's looking through the chart, not just at structured data, right? Our typical patient has, 68-year-old female with heart failure and, ESRD, on these meds, et cetera. Yes, of course we look at that. But we'll also look at what's been done for the patient in the past, what social determinants of health have been involved, what do their current insurance coverage cover, and not just in terms of meds, but potentially transportation home, what opportunities are being missed for this patient. And we align that into a complete plan. And we put that plan in place before discharge. So when they're leaving the hospital, we can get them a ride, let's get them a ride. If we need to make sure that they need meal support at home for the first 7 days, because the first 7 days on the outside are difficult, let's have that aligned for them, good to go. And so being able to identify these patients, rapidly create a clinical summary, and really just a very personalized summary of them, create a plan and assign tasks in those plans to agents within the Linea platform, as well as our own clinical team or their own clinical team, and then drive that all the way through really is kind of what led us to be quite successful. And at any point in time, and this speaks to the 80-90% patient engagement rate that we've had, patients can call or text us whenever they want. And they have a dedicated phone number. There's no app. Healthcare is not like Instagram where people want to log in and review things. No one wants to do that. But when they need something, they want to know, and they want to know that they're not going to be on hold or told to call back tomorrow or someone will get back to them. And so the reality is a patient can call or text us at any point in time. They'll be engaged. Sometimes they need to get a fallback call, but generally we are able to ingest that information of that outreach and give them a personalized response and plan as a result. Whether it's when they're on the outside, hey, when is my cardiologist appointment? We can give it to them in that second. Or, I want to stop my medication because it's causing, sexual dysfunction. We can alert their provider, readjust plan, suggest that plan to the provider, and prevent them from stopping the meds, which is, frankly, something that happened during the protocol and allowed us to keep the patient on track, instead of just stopping their meds because it was getting in the way of their quality of life. But yeah, these are the areas in where we've been able to align well to the patients and frankly, where we learned as we've onboarded more patients. Because when I started the company, I thought that text message would be the way. And what we learned is no, patients will text, patients will call, and it depends on who the patient is and a variety of other variables. So you have to be able to just willing to meet the patient where they are, and be ready to catch for that. And that speaks to a lot of the technology investment and the ability of the platform is we're able to meet the patient where they need to be, and work with them on their terms.
You're touching on something that is really important to me, which is the experience of care of patients, and not only in the acute setting, but then as they're discharged to home. And I wonder, Neil or others, but do you have a specific thoughts on how tech can really support that piece? How can it drive a differentiated patient experience or stakeholder experience for that matter?
Absolutely. I think one thing that, as Rishi was describing, the kind of the end-to-end experience there, anyone who has been building and been around healthcare, if you're novice to it, that would sound, oh, that sounds great, magical, all these things come together. But in reality, it's brutally painful to stitch all those different data sources together because they're sitting in different places, different permissions, different, possibly different standards change. And I think to make that experience possible, to make it as real time as Rishi's been able to do it, requires preparedness, having the information ready to be able to pull together, to be able to know all the things about insurance eligibility, medications, appointments, historical data, when they actually get to the hospital, what to do next, caregivers, transportation, all these sorts of things. Which I think, to your point, Francesca, is kind of creating this holistic experience. And I think Rishi also said something really important, which is, yes, we set out to build a company around congestive heart failure, but ultimately these are patients, they're not their condition. And you have to kind of treat the whole person and understand contextually what their situation is, what the relationship is with their disease. Does it define them? Does it not? And I think to that point, understanding them to the extent that you can. And one thing that I think, again, from an investment standpoint is, all the things that we're doing here in a world of abundance, let's say that we had all the resources in the world, a lot of these things would be very much possible. Some things still quite difficult and very manual and probably too slow. And I think so much of this is actually using technology to bring speed. And I think tying this back to your point is that speed, that understanding is what drives engagement experiences that, you're not repeating as a patient. It's like, I'm not repeating things that you should already know about me. You are, if I've told you that I like being called and not texted, next time, don't text me, right? And I think those kinds of things, it's like, okay, this care team actually cares about me as an individual, and they care about my, return to health, because, you're catching them at a point in which they are engaged, they're looking for solutions. They don't want to end up back in the hospital again. They want to go back to their activities of daily living. They want to go back to that soccer game, and they want to do that as quickly as possible.
And I think that's somewhat counter to what I would have thought intuitively, where I would have said, you need the human interaction with one person. But technology here really allows us to provide personalized care for each of those individuals, as opposed to just the few that you might be able to touch as a person. So I think that's a really good point to make. Steve, I'm sorry, I think I cut you off.
No, I would just add one point that I think is implied in what both Neil and Rishi said, but it's that all of these services that if you had talked about 4 or 5 years ago would have needed to be delivered at a cost structure that's just not viable. And it's technology that brings the cost to a place where, you know, organizations like ours can embrace them and bring that suite to patients in a way we couldn't have prior to the sort of the technology evolution that we've experienced over the last few years.
Speaking of cost, obviously there is an investment that needs to be made in any kind of endeavor, this one included. I know we live in a very fast changing investment environment, definitely not an area of expertise of mine. So Neil, could you kind of provide some insight to our audience in what are the considerations that they should be thinking about, and specifically how do they weigh on chronic disease management in these examples?
Yeah, I touched on it a little bit, but I think a lot of it has to do with capital efficiency. Steve was touching on this as well, which is around scalability of being able to provide the care at unit economics that are viable for both the end customer and the company, and the sources of capital. I think one thing that has kind of changed in this regard is really around, if you from an investor or a end customer or a payer's perspective, you kind of assume that outcomes are, if a partner is delivering a program to you, the outcomes that they're delivering are effectively table stakes. They have to do that. And if they don't, you select someone that can, right? You don't actually care what their cost of delivering those outcomes are, so long as, like, if they're losing money and you're saying, I'm going to pay you $1, but it costs them $1.20, they're just going to go out of business, right? And so it's incumbent on that partner to be able to figure out how much, what profit margin can I deliver so that I can continue doing this? How can I turn this into a business that ultimately I can reinvest into, what I do to make myself better? And as an investor looking in, we're looking for, how quickly can you get to, unit economics, gross margins that are, 50% plus, right? Which historically in tech-enabled services really only come with increased top line and risk upside or downside. And you can do that plus kind of even more. And the second side is, what kind of network effects do we see as we see more and more density, more patients that we see, more organizations that we connect with doing this more and more, so that there's a kind of defensible competitive advantage or a moat that exists through whether it's data or clinical outcomes or what have you, that I'll say is that another competitor that's looking into coming into this space, even if they try to replicate our exact same care model, copy paste our technology blueprint, they just will not be able to catch up as quickly as we can, because we have this kind of this head start in all the things that I just mentioned. So that's kind of a lot of the dimensions that we look for and when evaluating these kinds of businesses.
Got it. Steve, what would you add?
Yeah, I would just say it's a dynamic time as an investor, and I would flag that as a consumer of technology, and being at a company like DaVita, I think it's an amazing time where solutions are getting more efficient, more scalable, and doing that at a lower cost, which is really exciting for value-based care players like DaVita as a consumer. As an investor, I think it's actually a pretty hard time. For reasons that Neil articulated, you've also got a world where there's reimbursement uncertainty that maybe sort of exceeds what we've experienced for the last couple decades. And from an AI standpoint, what I would say, and this really builds off what Neil articulated, is that it's important to understand where companies have those advantages versus being a point solution that could be commoditized in a relatively short period of time. And for those reasons, both the reimbursement dynamics as well as the need to be nimble, I would say leadership is even more important as you think about companies you're going to invest behind, because the reality is 5 pivots will need to be made before that perfect endpoint is reached. Perfect endpoint is probably unrealistic, but there's just going to be a lot of twists and turns in the path.
I think that's, those are two really good points raised by both Neil and Steve, which is, coming from the Linea side and kind of quote the startup side, is how do we show the purpose of the heart failure program was to show in a very, defined nature, yes, we can hit outcomes, but then when we lift the hood, we show here are the processes that we've put in place with purpose. And the purpose is that, the traditional workflow for identifying and engaging patients, always meant adding more bodies to it, right? Adding more personnel. Whereas for us, we are able to, with very few personnel, be able to reimagine the nature of clinical operations and work, right? Be able to identify these patients in an automated fashion. What used to take hours to days of clinical summary and fraught with human error, because you have to interpret charts and kind of make your notes, we do in milliseconds at pennies on the dollar. And kind of create this, extreme efficiency. It pushed Linea to margins that I didn't expect us to hit until late 2026 to 2027, kind of following more of the traditional tech-enabled services approach, but using, generative AI and technology in a more thoughtful way, we've been able to hit these margins and exceed them much, much more quickly, right? By identifying what are the high cost and frankly, low human value, points that we can use generative AI to take over, and to what Steve said earlier, right? Elevate the quality across the board, guarantee a standard of quality of data interpretation, and really task our clinical teams and kind of the human effort to intervene at the right point in time where, oh, that is the right time for one of our NPs to pick up the phone and call, right? Or to review a high-risk situation and say, do we need to escalate this, right? And make that executive decision or de-risk and, create safety in that loop. And that's where I think the paradigm over the next few years for tech-enabled services will change. It used to be a space where, my next raise, how am I going to bring on more clinical staff? Because I want to bring on more contracts. How am I going to take on risk to boost my top line? I would, I'd argue that narrative has completely changed. Whereas now the approach is, how operationally efficient can you be? And because we're in this leapfrog moment of technology for healthcare specifically, how quickly can what the process I built out for heart failure be adapted to, where we're looking, right? So, CKD and ESRD to metabolic disease, because all of these are running together and we're treating them anyway. And that kind of expands out the impact we can have to these organizations. And I think that's what organizations are looking for long term, which is deal with an organization as well, with your pinpoint solution.
You touched on something that I want to go back to, but first, I would love for any of you to address this question from Michelle. How do you plan to bridge the knowledge gap in AI technology, especially among older adult patients who are mostly not tech savvy?
I would say we're in early days of, AI. And I think in reality, in a few years, like no one would ever say, I'm an internet company, right? Like we're all internet companies because we're all just use the internet. It's part of, it's like I'm an electricity company. Well, no, we all use electricity, right? You will use AI as part of your workflow, as part of it, right? And as the technology becomes better embedded into clinical workflow and into your systems that you're already using, you may not even realize that it's there, or that's the part that's done for you. And I think that's as, our engineering and our product experiences get better, it doesn't have to be so in your face, but rather it's like, wow, now I have this better capability, right? The first time you ever turned on spell check, it was really cool. Now you can, have your whole document written for you. You don't have to understand how that works. Very few people understand how the internet works, but I think that's where I hope that we're heading. But we are in a transition period. So over the next 5 years, it does take an understanding and you have to build trust with your provider specifically, to say, here is what the quote AI will do for you. And here's where you're still in control. And I think setting those expectations, the user expectation of how the technology can be used and how it should not be used, and then also reassuring them of what decision points they have full control over, or how you kind of get that adoption and education in place in the interim.
And I haven't experienced your platform directly, but it sounds like it's much more it's a better experience than the Delta agents bots that text me and have no idea what I'm asking. So I think it is about optimizing the product so that your counterpart, whether it's the provider or the patient, is willing and eager to engage. Speaking of which, there is actually a question. What do you do about a situation where you encounter non-collaborative hospitals or providers? They may not follow through with the personalized plan you have outlined or fail to respond. Who wants to take this one?
Yeah, I mean, I'll take a
Steve.
stab. Oh, go ahead, Rishi. Sorry.
Oh, it's fine. I don't mean to monopolize. I mean, so we experienced this. You have to understand where that's coming from, specifically if it's on the provider side, and so you have to remember that as a physician, right, what has my experience been with technology to date? It's been the EMR, right, which is an awful experience. You've created more work for me, more risk, and taken me away from what I love doing, which is taking care of patients. I don't want to sit there and document. So when you ever, and I carry that into every time we have to onboard a new practice or hospital and say, you really got to speak past that and say, we're here to help. We're here to increase reach, capacity, retention, reduce risk for you. We want to help. And we're not trying to take away from your revenue streams or, anything like that. We really want to support you. And if they're still resistant to that, you have to kind of get to the root cause of what's going on, and prove yourself essentially, right? So it's, hey, I don't have time for this, which is true. They don't have time for this. So what do we need to do? We need to figure out where they're already allocating time and not add 5 minutes, but say, listen, we can reduce that meeting time by 10 minutes. Just give me 5, right? How can I add value? And this goes back to like, if you're a builder listening to this webinar, you have to not just add value to the patient or to the ACO or risk-bearing entity, but you need to add value to every stakeholder in healthcare to be successful. And so this is adding value to your advanced, practitioners, your physicians. If I can add 5 minutes back to their day, if I can reduce the mental burden and the pain of reading charts and rather just get to the point, you got to give that to them. And when you add that value to them, then you over time can break down those resistant natures. If they still don't want to participate, I think you empower through the patient, and you have to come back around. And in time, listen, there are some people who are early adopters, some are middle, and some are late. And not every solution is going to be a fit for everyone, and that's okay. Steve, sorry, go ahead.
Yeah, I think this builds off what you said, but understanding where there are value drivers for them, and I think there's time and efficiency. I would just add that there's also readmissions. And if you can create a model that shows you can move the needle there and create value for them through some existing construct, that also has the potential to open doors.
For sure. There is one more question. It's pretty specific. What are you seeing in the way of AI agents in chronic care management, and how do you see this specific area evolving? Neil?
I can start. I'll take it more broadly. And Rishi, you can obviously talk about kind of how you're deploying them. I think Rishi framed, generative AI and then agentic AI, and specifically around agentic AI is, for folks that aren't familiar, it's AI that can actually perform tasks on behalf of people, and and do that in a way that is often proactive, more efficient, faster. And so when we think about how it's applied to chronic care management, there's a multitude of ways. I mean, if you think about it, agentic AI on the behalf of providers, it's kind of to the point of the last topic, which was around how do we make their lives easier? How do we help them with communication? How do we help them with information retrieval, things that used to be highly manual processes? On the patient side, I think this is also quite interesting. You think about how can managing chronic conditions or managing complex health conditions is a time-consuming task, scheduling appointments, communicating with loved ones, communicating with whoever it is that you need to, coordinating certain things. What we've started to see now is kind of patient-focused solutions that help on that end too. So I see it as kind of this healthcare administrative sides of healthcare, both on the patient side and the kind of the system side, the provider side of things, are draining. No one likes doing them, but it's the cost of doing business. And we can apply the agentic AI technologies to basically minimize the administrative burden that exists kind of on the system writ large. And in a lot of ways, one, improve experience for patients, and two, bring down a lot of cost on the overall cost of care side.
Rishi, anything you would add?
No, I agree strongly with what Neil said. I think when you have something that's so broad, AI being, this amorphous, concept at times, and then you drill down into generative AI and thinking about agentic AI, which is proactive, and then, generative AI, which we consider reactive. The best way that the way that we decided with Linea on how to deploy this, thoughtfully, because we don't have, infinite resources or time. It's kind of like when you decide to buy a hammer, right? Like, why'd you buy the hammer? Well, I bought the hammer because I needed to nail something. I had a nail and I had a board and I needed to, hammer it in. Hence, I needed a hammer. But I didn't start buying the hammer and thinking, like, what am I going to use this for? So you have to know what your endpoint solution is. And so that came from us understanding, through DaVita and through market research of like, hey, here's a problem. And we found this when we initially deployed with patients. We were spending 5 to 11 hours, clinical hours, identifying, engaging, and creating a clinical summary for patients, right? That's a long time. That's a lot of cost. And so can an agent or a series of agents do this better? Well, one agent mines that ADT feed and enriches it. The next agent will pull through that, clinical, documentation and create the clinical summary. And a third agent will create those tasks. Well, now I just took a problem that cost me, about $1,100 per patient in the first 7 days of a 90-day program and dropped it to a cost of $2. Now I have a reason that's why I deployed those agents. And we built from there. And, our approach has been around thinking of like the platform as, agent orchestration, right? So we have like this swarm of agents, and it's a way that we've expanded our team without increasing the human footprint too much, is that they're running different processes, and some of them are independent and some of them are interconnected. And it gives us more profound insight as we've gone through that 90-day trial, right? Or a 90-day kind of program. So another example for us was if a patient calls, right? There's what is said, right? I need an appointment with my cardiologist, but it's also how it's said. And that actually is an opportunity that's often missed when a human picks up the phone. And what I mean is, how fast were they speaking? What was their work of breathing? And taking that and comparing it to their last call, and then comparing it to their dynamic risk assessment of, heart failure readmission, and using those unspoken insights that's often lost, but can be quantified with an agent and technology to actually say, hey, you know what? This actually needs an escalated, cardiology visit and needs a reassessment. Let's run the diuresis protocol, which is its own set of agents, to actually identify and apply to this patient, right? And that type of new work is like your next step of evolution with agents, right? How are we reimagining clinical work to incorporate this ability of what couldn't be done, right? Identifying and looking at these data points, engaging the patients in what was previously unscalable manner and processes to a way that can be done now. And so that's how we think about, incorporating agents into that clinical workflow. Is it's either, reducing our operational costs while elevating that quality, or solving for specific problems, right? And looking for insights where previously we couldn't get them.
Got it. Steve, there is a question that I think was written for you and obviously for anybody else. What role do partnerships between startups and legacy healthcare organizations play in accelerating innovation without compromising care quality?
Yeah, well, first, I love the engagement and all the questions we're getting. Maybe first I'd say that DaVita is a fairly large company, and I am proud to say that I do think it's fairly innovative, and at the same time, I think we'd be naive to think that we can drive all the innovation that we need and want for our patients. And so for that reason, it is super important for companies like ours to create structures that enable them to connect with entrepreneurs and other innovators outside of the organization that enable paths to, again, identifying and infusing those innovative solutions that are being built outside of our walls. Maybe building off of that, I would say that the next piece of the puzzle is creating structures where you can support those companies as they seek to deploy inside of an organization that does have, robust compliance and legal and, other guardrails that can be challenging for a small company and, could otherwise, crush them, right? As you think about the burden of big company complexity. So it's really, to me, an infrastructure point that both enables a path to partnership and paves the way for pockets where those solutions can be tested in a safe and secure way.
Neil, would you add anything to that?
I would, yeah. I think one of the things that we think about is, from a company building standpoint and tackling something as, complex as this, it's, there's kind of shared DNA between us and a partner like DaVita. So when I saw a legacy, I kind of bristled at it because I don't really see DaVita as a legacy organization, because I think legacy organizations don't engage in partnerships like this because they, it's a willingness to take risks, to do things differently. And I would say when we kind of embark on those types of relationships, we're looking for, this kind of willingness to kind of engage in different types of payment models, pushing forward, understanding that building takes time, and there'll be time before value is delivered both financially and to patients. And then there's a kind of an appetite to kind of take that risk and a very long view on this. If you said, I need this right now, you don't embark on company building. You look for what's available in the market, or you continue to do things the way you do them. From the moment in time we started the conversations, while we like to move fast, it was, probably a year and a half before, and that was actually quite fast, that before, Linea was in market and starting to see patients, that was well ahead of timelines. We kind of set expectations that it'd be 2 years or more potentially, but it's because you're trying to do something quite different. And so, there's obviously different types of partnerships. Company creation is a very specific type of one. It's definitely not for everyone. But for those that are kind of seeking to do this, I'd say make sure that there's kind of shared understanding, shared vision around the kind of the duration of this.
Yes, and having only been, marginally involved, I think that was really the secret sauce to this partnership, was the close collaboration between you guys and all the stakeholders across DaVita. Rishi, there is a question that is, I think, directed to you. How do you ensure that AI algorithms achieve medical grade accuracy and avoid the deviations commonly seen in LLMs? I don't know what those are.
It's awesome. I love this question. And again, we'll try to not take up the rest of the time going down a rabbit hole. But one is understanding, again, why you're deploying an LLM. So some workflows that can be completely agentically run, non-clinical workflows, right? Scheduling a follow-up call with a cardiologist, or potentially just calling the cardiologist and working through the phone tree and then handing it to my patient navigator to do the call and get the appointment. Sounds very simple, and can be deployed very rapidly and easily, but saves me 10 to 12 minutes per patient, which is huge. And some of these, quote, small interventions allow Linea to do something that I have not seen in other companies, which is 4 hours of human work yields, that 12 to 16 to 18 hours of patient engagement over 90 days. That's when I talk about like how this changes the game. Now, when you talk about, LLMs and models potentially making medical decisions or medical recommendations. So you could take, for example, like the way that we generate GDMT protocols for all of our patients. One is you can take models that perform for this, and I'm not going to name any names, but they're all out there. And many companies take what's called prompt engineering, and they'll just, engineer a prompt or, to kind of extract what they want. over time, what you start to do is we've created this more common backend of data. So we say, listen, don't just look at the whole world, look at our world of what we care about, of what our protocols mandate and what's unique to this patient, and run the model based on that, right? Not on everything. So we're avoiding kind of like the randomness of taking all knowledge and focusing a back-end brain that just focuses on clinical knowledge. And then generate me a GDMT protocol that gives me meds, titration, dosage, alternative economic options based on coverage that are very specific to the patient. And then the next layer is kind of bringing in the human in the loop. And this is to allow us to, especially in the early days and years of this, to introduce like safety and quality, is bringing in a human to not spend the effort on generating that plan, but signing off on it, right? So we use a clinical pharmacist to say, hey, like, does this make sense, right, in QA? And when there needs to be a change, make the change, but let the system learn from it every time there is a change or a contraindication or an quote error made. In Linea's current deployments, this process has allowed us to basically go from when we ran just a human process to do this, meaning the typical run the chart or even just have a clinical pharmacist review, we had some mistakes when we were running in a traditional way. Whereas the generative AI enabled way with a human in the loop to check safety and quality, creating a lot of efficiency, has led to a lot less errors as well. So we're able to move time to treatment faster, higher quality, and much more scale, right? And so that's, how we do it. But on the back end, it will be, as more of these models are fine-tuned and then foundationally built, you will have improvement in its medical decision-making capabilities. But again, while we're in the early days, and for a company like Linea, you have to decide when is the right point to sacrifice some of that quote efficiency and bring a human in to do the review. And that's one of our approaches to avoid those types of mistakes where it's a high risk situation. No clinical plan reaches a patient without our internal team looking at it or making sure it's gone through a cardiologist or nephrologist for approval as well.
So it's really the synergy between machines and humans. We cannot live without each other, which I think it makes more sense for those of us who are maybe the later adopters, to go back to Neil's prior statement. Surprisingly to me, we only have 7 minutes left. So to each of you, 2 minutes. If you wanted to highlight one concept, one idea for attendees of this webinar to take back, what would that be? Neil, do you want to go first?
Yeah, sure. I think, there's going to be a varied level of, dependence on AI and technology. And I think one thing that everyone should remember is that, we've redesigned, we talk about kind of the traditional model of moving fast and breaking things doesn't work in healthcare because, patient lives, patient health, people are in the balance, and we can't really make unforced errors and mistakes. We can take risk, but we have to do it in a responsible way. And I think one thing that Rishi mentioned here is really emblematic of the approach is that, we can push AI to the boundaries, but we can't put it out there without understanding that, we as leaders are ultimately fully accountable for what the technology does with us, for us, on our behalf, right? And so I think that's the key takeaway here is that shouldn't stop us from pushing the envelope, from innovating, but we need to be also, very mindful of what the limitations are and, deploy things in a very responsible way.
Thank you so much. Steve, do you want to go next?
Sure. I've reflected on this a little bit in thinking about it through the DaVita lens. And I just say, I think we are at a very unique moment in history where massive change is happening. And as you think about organizations like ours, I think it's the incumbents who are willing to embrace change that will ultimately survive and thrive and have the biggest patient impact. And what that means to me in the context of AI at DaVita is that we can't have a small team that is figuring out how to embrace and deploy AI, it needs to be something that is pervasive throughout our workforce. And when we have a bit of and this is a phrase Rishi uses a lot, but an AI first mentality. And as problems come up, everyone is empowered to say, how can AI be enabled or enable us to tackle this in a unique and differential way that lifts us all up and enables us to do more for our patients.
Thank you. Rishi, you have 3 minutes.
I think that there's always been, like, throughout my journey in startups, there's always been this promise, right, of opening up access to care and scaling it. And I used to always think about the idea as a physician, like if every one of my patients like texted me today, it would just be overrun and actually be more risk. And that's frankly a lot of the provider sentiment, from prior years. And I think we're entering into, for the first time, that opportunity and that dream can be realized of like scaling high quality care in a sustainable way, right? And when I say sustainable, I mean like an operationally sustainable for health systems and for payers and risk-bearing entities. In that, we're able to orchestrate data that's there and data that couldn't be quantified, right? Into insights and then into action and follow-up care for our patients on a deeply personalized level. But then at the same time, take that one line and scale it across an entire population. And for what we're seeing in Linea and for what I'm seeing in the industry, it's just over the next few years and potentially even in the next few months, you see it changing the way we're thinking about, clinical work, and what we can do for our patients, but also what these organizations such as DaVita can do across the organization, right? And how we can empower our patients to have more and do more, how we can enable our workforce to have a more fulfilling and enriching career as well, in terms of empowering them away from that clerical work and into more meaningful and high value tasks. So it's exciting times.
It definitely is exciting. One thing we haven't had the time to touch on is, Linea started focusing on one very specific clinical application, which is congestive heart failure. But as a clinician, I see so many other potential areas where the type of efficiencies that can be gained through this type of approach could give providers and patients such a profoundly different experience, as well allow clinicians to really focus on the stuff that we want to focus on. So that has been really eye-opening for me. As the attendees probably can have guessed, I was a pretty confused, and I still am a pretty confused user of AI. But I would like to really thank each of you, because I come away with a refreshed perspective of how this can be a new, better tool, like a new hammer that I didn't know I needed, and I just need to learn how to use it. So one suggestion for you experts is facilitate for those who are not. Help us understand how we can best use these tools, because I think that it's also a big void that needs to be filled. So you're all on task for this, Rishi. You will need to educate all of us. I would like to thank each of you who has been with us for the past hours. I think this was a really enriching conversation, at least from my perspective. And again, just thank you all for your time.
Thank you to DaVita and to everyone that joined us today. Please visit our website, HLTH.com, to catch up on all health webinars and to watch the recording of today's session. Join us in Las Vegas, October 19th to 22nd for Health USA.